بسم الله الرحمن الرحيم. أبنائي الأعزاء، أنا دكتور مجدي موسى، أستاذ ورئيس قسم طب وجراحة العين في كلية طب طنطا، والمحاضرة بتاعتنا النهاردة part of the special sense in this semester. وطبعا احنا نظرا للظروف اللي بتمر بيها البلاد والكرايسيس اوف كورونا المحاضرات كلها اونلاين. يشرفني يكون معاكم النهارده. محاضرتي النهارده هتكون optic nerve and the retina. So today lecture is going to be about optic nerve and the retina presented by me. What are the objectives of this lecture? By the end of this lecture, you should be able to define common optic nerve and retinal lesions and identifying the causes of visual loss related to posterior segment of the eye. Posterior segment means the retina and the optic nerve, and list the signs and symptoms of different retinal vascular disorders and optic nerve disease. Let's start by the optic nerve. The optic nerve starts at the lamina cribrosa as a collection of axons of ganglion cell, which we call retinal nerve fiber layers, and it is called the optic nerve head. This is the start. The picture here showing the optic nerve head, which we see inside the eye. The optic nerve is rounded, pink in color due to vasculature on the surface. It is flat with the retina, and it has well-defined border as we see, and the vessels coming in and out. The central retinal artery is coming out from the optic nerve, and the central retinal vein is going inside the central retinal vein. And this is the deep cup where we can see the vessels coming in and out. And this is the optic nerve head. As we said, start here by fenestration in the lamina cribrosa, which will accommodate the retinal nerve fiber layers, and it ends by the optic chiasm in the brain, and between the pupil and the chiasm, the optic nerve has four parts. And this is illustration of vertical section through the optic nerve where the retinal nerve fibers coming through, and the lamina cribrosa is a fenestrated sheath زي المنخل where the retinal nerve fibers pass through, and we can see the retinal vessels inside the optic nerve. This diagram and this CT scan showing the parts of the optic nerve. We have the optic nerve head, which is the intraocular part. It's about 1 millimeter in length, and then the part behind the globe, which we call the intraorbital part, which is 25 millimeter in length, and then the intracanalicular part, which is about 9 millimeter in length, and the intracranial part, which is 16 millimeter in length. So these are the parts, and this is a CT scan showing exactly the parts we see when we do CT scan for the patient. What are the optic nerve diseases we are going to discuss today? We will discuss the papilledema and the optic neuritis. Papilledema, by definition, is a passive non-inflammatory swelling of the optic nerve head, as we can see here, inflammation and non-inflammatory swelling, and secondary to increased intracranial tension. So it means that it happens due to increase the pressure inside the brain. Optic neuritis is different. It's a primary inflammation of the optic nerve, and it could be optic nerve head itself, we call it papillitis, or the part behind the eye, which we call retrobulbar neuritis. And there's a big difference between the papilledema and the papillitis, as we see by the fundus picture. Congestion, elevation, marked elevation. In the papillitis, there is mild congestion, there is minimal elevation, and there is no tortuosity much of the vessels like in papilledema, and we will explain that in a minute. What are the causes of papilledema? Papilledema mainly is due to increased intracranial pressure due to brain tumor, neoplasm. 70% of cases are caused by brain tumor, as we can see here in these two pictures, MRI and CT scan. We can see the neoplasm pressing on the brain and pressing on the CSF, which is reflected on the optic nerve, and we can see it inside the eye by papilledema. And as they say, the fundus is the mirror of the brain. So because the pressure is reflected inside the eye, even without doing this, we can detect that there is something wrong in the brain. Papilledema always bilateral, and sometimes the optic nerve is atrophic in one side, and it is papilledema on the other side. We call it Foster-Kennedy syndrome, and it's explained by frontal lobe tumors. Even we can diagnose where is the tumor by looking at the fundus, because in the frontal lobe tumor, the direct pressure on the optic nerve by the frontal lobe tumor in one eye, and the other eye papilledema due to increased intracranial tension. Papilledema also could be due to inflammation, meningitis, inflammatory brain abscess, tuberculoma, like a granuloma inside the brain due to TB. It could be vascular, like subarachnoid hemorrhage and cavernous sinus thrombosis, and this is an example of subarachnoid hemorrhage due to trauma, severe head trauma. Blood is accumulated in the subarachnoid space, and subarachnoid space, and it will press on the brain, increasing the intracranial tension reflected inside the eye as papilledema. And the last thing, what we call pseudopapilledema or pseudotumor cerebri. Pseudotumor cerebri means benign increased intracranial tension with no intracranial lesion. We don't find tumor, we don't find subdural hematoma, and that's why they call it benign. In papilledema without the tumor mass or inflammation. Clinical picture. What is the clinical picture? How the patient comes in. The patient sometimes is not complaining. There is no much complaint, especially in early cases of papilledema like this. There is mild pressure. Sometimes they don't complain. They don't say any complaint, but you discover this accidentally. And sometimes they come in with amaurosis fugax, which is transient attack of blurring of vision due to sudden block of transmission along the optic nerve and spasm of the intracranial arteries. So once you have a complaint like attacks of blurring of vision, you have to examine the fundus. Other associated symptoms, which is very important, is increased intracranial tension as headache, vomiting, diplopia. And this happens due to sixth nerve palsy, pressure on the sixth nerve by increased intracranial tension. And we know the sixth nerve is the most vulnerable one because it runs a long course along the bone and it's easily be damaged and compressed. The late signs, as we see here, the picture, gradual painless diminution of vision due to progressive optic atrophy. It ends up with atrophic changes due to continuous pressure on the retinal nerve fiber layers, and patient comes later on by diminution of vision, which was gradual, and we will find out that this patient already had a papilledema and he passed through the phases and he ended up with optic atrophy. How about the signs? The optic disc, we look at the fundus and we look at the optic disc. We can see it hyperemic with blurred edges, filling of the physiological cup. There start to filling of the cup. Then later on, the optic disc is markedly elevated above the surrounding retina. It's not flat anymore, with sometimes hemorrhage on its surface, and there is marked congestion of the retinal veins due to back pressure on these veins. The disc later on may show mushroom-like shape in advanced stage where the disease becomes chronic, like chronic papilledema, and this has to be differentiated from other causes of elevated optic disc. Papilledema due to BIH or benign increased intracranial hypertension or idiopathic intracranial hypertension, IIH, as medical treatment can sometimes is successful. So disc edema may resolve, as we can see here, the edema started, but it is resolved completely after medical treatment. And sometimes if the pressure is continuous, they do shunt operation like transforming the CSF circulation into the peritoneal cavity. Let's move to papillitis and optic neuritis. What are the symptoms of papillitis? The patient presented with what? Rapid marked diminution of vision. Why rapid? Because it's inflammation. Any inflammation of the optic nerve will hinder the function, so the function is vision, and the vision is markedly affected, and especially the color vision. The patient come in with diminution of vision and he cannot differentiate most of the color, like the red, green, and blue. Vision may decrease down rapidly to hand motion in few days. This is very important to differentiate between papillitis and papilledema. The vision stay for a long time, good vision in papilledema, but in papillitis rapidly deteriorating. And we look at the fundus, we see the signs. Hyperemic disc, it is not that markedly elevated. Sometimes the edges are ill-defined, and the disc is hyperemic because of the congestion sometimes on the vessels because of the inflammation. And the elevation is not exceeding 3 diopter, which means when we examine the patient fundus by ophthalmoscope, we have diopteric power to increase 1 diopter, 2 diopter to make the optic nerve in focus. So the elevation, we don't use more than 3 diopters in the ophthalmoscope, but in papilledema, it can reach up to 9 disc diopter because of the marked elevation of the disc. The vitreous is turbid. We look at the vitreous, we examine the vitreous, we find vitreous cells or opacities due to presence of inflammatory cells. And the most important diagnostic tool is fluorescein angiography, where we inject the dye and see the inflammation and staining of the optic disc at the late phase of the angiogram. How about the retrobulbar neuritis? Inflammation of the optic nerve, only the part behind the globe. So we look at the fundus, we see nothing. There is nothing on the optic nerve head. There is no much hyperemia. There is no elevation, well-defined edge. And we look at the fundus and we see nothing. We tell the patient we don't see any changes inside that. But the patient also say that I have marked diminution of vision, and he also see nothing because he's not seeing by this eye. So this is the expression. The patient see nothing, the doctor see nothing, and still there is inflammation of the retrobulbar part of the optic nerve. How we can define that? By the signs. Look at the fundus, there is nothing in there, but there is tenderness on pressure of the globe. There is pain on moving the eye, which the patients come in sometimes and say, I have pain while I'm moving my eye. Why? Because in the retrobulbar part of the optic nerve, there is meningeal sheath. Inflammation of this meningeal sheath is reflected on the sheath around the muscles, which is attached to this meningeal sheath. And that's why when the patient moves his eye, he feels pain, which is completely different from papilledema, where there is no pain in moving the eye. What is the fate if we leave the papilledema or papillitis without treatment? We ended up with secondary optic atrophy. We call it secondary because the disease is in the optic nerve, either papilledema or papillitis. And we look at the optic nerve, it becomes pale. There is not hyperemic anymore. The edges are bleared, and there is sheathing over the optic nerve head, and due to proliferation of the astrocytes. So it's ill-defined because of the fibrosis on the surface. The vessels are attenuated and sheathed, and the optic disc becomes pale, and this is what we call secondary optic atrophy. The next part of the lecture is the retina. The retina, as you took in the anatomy, is a transparent membrane, extends from the optic nerve to the oris areata, start from here at the edge of the optic nerve to the extreme periphery, which we don't see in this picture, which we call oris areata, which is serration-like. While it's transparent, why we see a red color when we examine the fundus? Because this is the color of the choroid seen through the transparent retina, and we see a red color in the fundus. Today we are going to speak about certain disease like central retinal artery occlusion, central retinal vein occlusion. Other retinopathies, you will have it in the endocrine, like diabetic retinopathy, retinopathy of prematurity in the pediatrics. And we will speak about retina detachment, either primary or secondary retina detachment, where the retina is separated from each other. Let's move to the most common disease we'll speak about today. It's a central retinal artery occlusion of the main blood supply of the eye. And occlusion of central retinal artery is cutting off the blood supply of the retina, end up with a sudden painless loss of vision. The patient comes in, he sees no light. He say, something is black in front of my eye, I don't see anything. And because it's an end artery, there is no anastomosis, there is no collaterals like in the well circle in the brain, so it ends up with blindness within 60 minutes if the artery is occluded. Why the artery is occluded? Because different reasons. It's the same reason of occlusion of any artery all over the body. Let's start by thrombosis, thrombus formation inside the artery. And it happens in old age, like in diabetes, hypertension, and arteriosclerosis, where the factors facilitating thrombus formation are there, and we can end up with thrombus inside the central retinal artery. The second common cause is embolism. Embolus means some foreign material is inside the artery. It could be, again, a thrombus coming from the heart, or it could be different material like vegetations on the heart valve in rheumatic heart disease and endocarditis. And also it can come from the large arteries like atheromatous lesion in the carotids. As we can see here, we can see atheromatous lesion where cholesterol is deposited, and then showers of this cholesterol will move with the circulation. And these are examples or the sort of embolism. It comes from the carotid, large arteries, and it moves to the central retinal artery. The third least common cause is the spasm, transient, and it causes transient, as in migraine and malignant hypertension, but sometimes the spasm persists, which lead also to complete loss of vision even after the spasm release. This picture showing small cholesterol emboli entangled at the bifurcation of the artery, and we can see the small yellowish particles. These will be called emboli or cholesterol emboli. What are the signs and symptoms? Symptoms, as we said, the patient is presented with sudden painless loss of vision, no light perception or no perception of light. What are the signs? We look at the patient, we examine the pupil. Pupil is dilated, non-reactive to direct light, but if you use the light on the other eye, we call it consensual reaction because of the decussating nerve fibers in the chiasm. But looking at the fundus, we look at the fundus, it's not red anymore. There is a milky white retina, whitish coloration at the central part of the eye, with cherry red spot, with a red spot in the center. This whitish coloration because of the thickening of the retina, or coagulative necrosis, or early edema of the retina, which obscure the color of the choroid. Why this red color in the center, which we call cherry red spot? Because we can still seeing the color of the choroid through the thin fovea, where there is no layers in the fovea, only the retinal pigment epithelium and photoreceptor, and that's why we can see the cherry red spot. What are the other diagnostic signs? When we do fluorescein angiography injecting the dye to see circulation inside the eye, we can see what we call cattle track appearance, black and white, segmentation of the column inside the artery. This is segmentation due to slow circulation inside the artery, and they call it cattle track because the cattle in US are black and white, so when they are following up the cattle in trucks, they see black and white from far away, so this looks like a cattle track, black and white dots due to segmentation of blood inside the vessels. The next part is the central retinal vein occlusion and occlusion of the central retinal vein. Also, the etiology is almost the same at the artery except the embolism. We cannot have embolism in the vein, but we can have diseased or sclerotic vessels as in old age, diabetes, hypertension, and arteriosclerosis. It could be inflammatory occlusion of the vein, and the inflammatory condition affecting the retinal vessels not only in the eye, but it can be also in systemic vessels. And it can happen in young age, like infective periphlebitis and typhoid fever. There is inflammation of the vessels all over the body, and it can affect the central retinal vein. In some autoimmune disease like Behçet disease, which is an autoimmune affecting the vessels all over the body, especially the veins, with the periphlebitis, and they call it occlusive vasculitis. And it can be manifested by other systemic conditions like aphthous ulcer, genital ulcers, multiple nodules all over the body, and it ends up with occlusion of the central retinal vein. Third thing is intravascular abnormality, blood stasis with increased coagulability as seen in severe dehydration and polycythemia. That's why it's very common to find the patient presenting with central retinal vein occlusion while they are doing some exercises, losing some water and dehydration, and they don't drink much. Also, it can happen at night because of the stagnation of blood and thrombus formation ability. The last cause is extravascular cause, pressure on the vein by orbital tumor or inflammatory orbital cellulitis or hemorrhage. Like the picture here in the left side, this patient had a tennis ball trauma with severe hemorrhage under the skin, under the conjunctiva, inside the eye, and in the retrobulbar space behind the globe, where it presses on the optic nerve, and the optic nerve has the vein and artery, and the first one to be occluded is the vein because of the pressure inside the vein is lower than the pressure inside the artery. What are the symptoms? The patients come in with rapid painless diminution of vision. It's not loss of vision, it's diminution of vision, and it's rapid and painless also, and usually discovered in the morning, as I said, because of the venous stasis, the ability to thrombus formation during sleep because of stagnation of blood, and it's very good condition for the thrombus to be formed. Visual acuity varies from mild to severe. It could be 6/9, 6/12, and severe visual loss, counting fingers. Sometimes the patients come in with a very low vision, and we differentiate this from ischemic and non-ischemic type of central retinal vein occlusion. This is an example of the first picture of non-ischemic vein occlusion where the manifestation is there, congestion on the disc, disc edema, congested vessels, tortuous dilated vessels, and macular edema is mild. And the ischemic type sometimes is severely affecting by massive hemorrhage, massive edema, and exudation. Why we classify vein occlusion into non-ischemic and ischemic? Depending on a theory that the occlusion happens either anterior to the lamina cribrosa inside the eye before the vein enters the optic nerve, where the thrombus is formed here and there is no collateral vessels to bypass the increased intravascular pressure, while if the thrombus happens behind the lamina cribrosa inside the optic nerve, there are a lot of collaterals between the central retinal vein and the veins surrounding the optic nerve inside the meninges. So these collateral vessels will relieve the pressure, make the manifestation is much less in the non-ischemic type. Let's speak about non-ischemic central retinal vein occlusion. As I said, dilated tortuous vessels. Why? Because we are having thrombus in here, preventing the venous drainage, so the veins are congested and dilated, and there is mild to moderate retinal hemorrhage, few spots. Sometimes you don't find macular edema. There is no much fluid because the rupture of these capillaries lead to hemorrhage and fluid, which will accumulate in the most dependent part, which is the fovea. However, the ischemic shows very aggressive picture, massive hemorrhage because of the capillaries are mainly ruptures, many capillaries, a lot of ischemic areas, severe venous congestion, and severe disc edema. And we find diffuse macular edema, which is the cause of marked diminution of vision plus the hemorrhage, which can affect the macula, and also optic disc edema because of the congestion of the vein at the optic disc and impairing venous drainage. Last part of our lecture is retinal detachment. What is retinal detachment? Separation of the retinal layers with accumulation of the fluid under the sensory retina, and separation between the retinal pigment epithelium and the sensory retina by subretinal fluid. What are the types of detachment? As we can see, it's a primary retinal detachment. We call it regmatogenous because it is related to retinal tear or break, or something is torn inside the retina. And secondary attachment, where we find no break, but it could be exudative or tractional retinal attachment, as we will speak in a minute. So the main aim is accumulation of fluid under the retina. This is an example of regmatogenous, where there is a break in the retina, the vitreous becomes gel and pass through the break and start to detach the retina. So let's start by regmatogenous retinal detachment or primary retinal detachment. It occurs secondary to full thickness defect or break in the retina, and that's the nomenclature coming from. Regma is a break in the sensory retina. As we can see here, this is a rounded break, or we call hole. There is a horseshoe break, and this is we call horseshoe tear. So the tear can be different types and shapes, and it's almost present in the periphery, and fluid start to come in, elevating the retina. What are the predisposing factors when people get regmatogenous retinal attachment? If they have myopia, and high myopia, sometimes there is liquefaction of the vitreous, and there is elongation of the globe with a stretching of the retinal periphery, and during stretch, the vitreous is strongly attached to the retina and the periphery, breaking part of the retina, causing the break, and then followed by retinal attachment. Severe blunt trauma with coupe and countercoupe of the vitreous and leading to tear in the periphery of the retina, and then followed by retinal attachment. Peripheral retinal degeneration, weak areas at the periphery, like lattice degeneration, which is also present in high myopia. And there is aphakia, sometimes complicated cases during cataract extraction, will lead to formation of a break due to traction by the vitreous on the periphery of the retina. So this is a picture of large retinal break, where the fluid passing through this break, coming to the macular area, and this is the cause of diminution of vision. Let's see what are the symptoms. Patients come in with what? Sometimes at the beginning, only musca volitans, vitreous floaters. You see a lot of black objects, which sometimes looks like a, زي حرف الواو, or there is a comma-like. Sometimes it's rounded, sometimes it's large, sometimes it's web-like. Where this vitreous floater is coming from? Following blunt trauma, sometimes it's hemorrhagic cells. Following blunt trauma, sometimes it's cells coming from the surface of the retina floating in the vitreous. And sometimes it is due to vitreous liquefaction, which happens, as we said, in old age or in high myopia, and start to have some retinal cells inside the vitreous. And the patient comes in with this, especially after severe blunt trauma or inflammation, comes with this musca volitans, and he starts to complain that he's having some black subjects in front of him. Then the second common manifestation, when they are combined together, the photopsia, flashes of light. The patient say that I see flashes of light, especially in the dark. And this is because the vitreous becomes degenerated. Some of the vitreous is still attached to the retina. Pulling on this retina will cause irritation of the photoreceptor, and the patient starts to see flashes. So it means that the vitreous is going to be separated from the retina, and it might tear the retina or making a break inside the retina. So these are very important two symptoms. Floaters and flashes, especially after blunt trauma or in high myopia, it has to be examined thoroughly to find out if there is traction on the retina. Then comes to the retinal break. They said that the flashes are increasing, that the floaters are increasing because of the cells are floating inside the vitreous, and this is the site of the tear where the traction caused break at the periphery of the retina, and then the fluid start to go through because the vitreous is liquefied, pushing the retina, elevating the retina, and at this stage, the visual field will be affected. The patient will say, if the fluid is in the upper part of the retina, you say, I have lower scotoma. Something is obscuring my lower part of the field. And once the fluid increase and reach the macula, there will be sudden drop of vision. And the most common complaint that the patient say, I have a curtain, black curtain coming from up, and down, and then goes down, and then I lose my vision suddenly because of the macula involved by the detachment, and where the patient comes in and saying, I'm seeing nothing in the central area. What are the signs? We look at the fundus, and we have to examine the retina thoroughly, but sometimes before looking at the fundus, we look at the pupil. Sometimes if the retina is completely detached, we see that the red reflex is grayish because of the retina is elevated and wavy. We don't see the color anymore, and sometimes we see a grayish reflex inside the pupil. because of the detached opaque retina. But examining the fundus, we have to find out the tear. This is a horseshoe break, and this is a hole. Sometimes we catch the patient early, a hole without detachment, and we can seal that by laser. But once the detachment happens, it has to be surgery. And the retinal breaks can be multiple like this, and the retinal surface is elevated by the fluid, and it will be convex in nature. And this is the retinal detachment, convex anterior displacement of the retina with convexity, and we can see that the macula is detached, and this patient comes with sudden drop of vision after flashes, floaters, and scotoma. How about the secondary retinal attachment? Secondary retinal attachment, we said we have two types: exudative retinal attachment, which is caused by something under the retina, pushing the retina from below, like in the choroid, and making fluid accumulation under the surface of the retina, like choroidal tumors. Malignant melanoma of the choroid can cause exudative retinal attachment. Choroidal inflammation, like Harada disease, which is an autoimmune disease with a multifocal inflammation in the choroid, pushing the retina like this, multifocal inflammation, and then fluid will be accumulated in the central area. Or degenerative disease like age-related macular degeneration. We have something called choroidal neovascular membrane, happens in the choroid, which will lead to hemorrhage and exudation and elevation of the central retina, and these are all causes of secondary or exudative retinal detachment, which means a lesion under the retina, accumulating fluid and pushing the retinal layers to be separated, causing exudative retinal detachment. The last type of detachment is, or the secondary type also, tractional retinal detachment. Tractional retinal detachment means something is pulling on the retina from the surface. So the retina is pulled away from the RPE by contracting vitreous membranes like this. This is a proliferative diabetic retinopathy, advanced stage of diabetic retinopathy, where a lot of membranes, a lot of fibrous tissue happens because of the bleeding and long-standing diabetes, which can cause traction on the surface of the retina, leading to what we call tractional retinal detachment. And the most common cause, as we said, proliferative diabetic retinopathy, other retinopathies like sickle cell retinopathy. RVO can cause hemorrhage and fibrosis in the vitreous, and can cause traction retinal attachment in advanced stage, and sometimes penetrating posterior segment trauma when patient had a foreign body inside the eye, initiate fibrosis and reaction, which cause tractional retinal detachment. This is an example of old branch vein occlusion where the fibrous tissue happens due to the hemorrhage, long-standing hemorrhage, and there is a traction on the retina, and we can see pulling on the retina and distorting the retinal vessels and fluid accumulation under the retina. This is the end of my lecture, but let's have a couple of questions like testing your knowledge. The first MCQ question I will give you, depending on the lecture, what the passive non-inflammatory swelling of the optic nerve head is termed or is called: papillitis, papilledema, or retrobulbar neuritis. So it's obvious it's papilledema because it's passive, it's non-inflammatory swelling of the optic nerve head, and the right answer is papilledema. Second question in the form of like a small problem we need to solve it, like 60-year-old male known to be hypertensive for 5 years. He developed marked diminution of vision in his right eye, started 5 hours ago. The patient described the diminution of vision to occur suddenly. It means he opened his eye, the second he doesn't see anything, and on examination the visual acuity was no light perception, he's not seeing anything, pupil dilated, non-reactive, and the fundus is milky white with a cherry red spot. So which one of the following pathologies can be the diagnosis of such presentation based on the lecture we had? Is it acute angle closure glaucoma? Is it central retinal artery occlusion, central retinal vein occlusion, or papilledema? And it's obvious that sudden, painless loss of vision is the central retinal artery occlusion. Last thing, short AC questions when it comes in the exam. We ask you to enumerate 4 signs of optic neuritis. We have many signs in optic neuritis as we spoke in the lecture. Could be decreased visual acuity, blurred edges of the optic disc, filling of the optic cup, elevation of the optic disc over the retina, not much elevation, but there is elevation, turbid vitreous and tender globe while we move the eye, or pain on eye movement. So it means we have many signs, only 4 of them you will get the mark. Thank you so much for your listening, and I hope the crisis will pass and everybody stay safe. And this is my email for further communication if you need to communicate with me. Thank you so much for your listening, and this is the end of the lecture. I'm Dr. Magdi Musa again, Chairman and Professor of Ophthalmology, Faculty of Medicine, Tanta University. Thank you so much.